It's my great pleasure to introduce our first speaker, Gail Wilensky. Gail is one of the nation's top healthcare economists and a senior fellow at Project Hope. Gail has an incredible record of public service. Under President George H.W. Bush, Gail was a senior advisor to the president on health and welfare issues, and she led the organization now known as CMS. Under President George W. Bush, Gail was an active member of 2 presidential commissions aimed at improving health care for our nation's veterans. She was also the first chair of MedPAC. Well respected on both sides of the aisle, Gail is frequently called to testify before Congress. She's also a sought-after advisor in the private sector, serving on the boards of several major healthcare companies. In fact, today she's going to have to leave right after her remarks because of that. She's been a valued friend to NICM through our 25-year history, and she is someone who I have looked up to, not physically, but in other ways I've looked up to and learned from. So with that, Gail. There's a stool right there.
The only people who look up to me physically are my 2 youngest grandchildren. And the youngest granddaughter is clearly gaining on me quickly, so it's going to be down to 1 soon. It's a pleasure to be here. This is a very interesting session, and it's coming at a very interesting time in our history because of the enormous amount of innovation that we are seeing that is part of the medical device, pharmaceutical delivery systems that we all use, and the kinds of promises that we can see coming in our future, particularly with artificial intelligence and some of the other many promises that are yet to come. As the person who is setting the stage for the other talks, and as Nancy indicated, unfortunately I'm not going to be able to stay to hear them because of other commitments. As a person who's setting the stage, I was asked to talk about the differences or the different roles for the government and the private sector in terms of innovation in healthcare. Frequently over the years, people have asked me some variant of which does it better. It can be in terms of payment, it can be in terms of innovation, as is the case today. And basically, in almost all of those instances, it's not a matter of which is better. It's that each of them is better for some things, but not all things, and that there are other areas where the private sector is better than the public sector. And that's certainly the case when it comes to innovation. They both have relative strengths, and they both have cases where the other is the stronger. When I look at the basic divisions in the question of where is the government stronger and where is the private sector the strongest, there's some things that jump out at you right away. If you're talking about basic bench sciences with few commercialization prospects, or where there may be ultimately someday but there's high levels of uncertainty, and they're a long way down the lead in terms of the time before you will see them. If you're talking about very large-scale changes, it is hard for the private sector to pull that off in a way that government can do. But if you're talking about new products, new payment models as a strategy, or commercializing new products, generally speaking, the private sector is able to do those kinds of changes much easier. It doesn't have to go through the administrative procedures act, and it doesn't have to follow other regulatory structures that are around that the government has to follow. But only government can produce large changes on a very specific timeline. And I'm going to give you some examples, but I suspect some are going to come to mind immediately. So as I've just indicated, if you're talking about developing a product that has unknown applications, or you're pretty sure there may be applications, but it is unclear how long it will take, some of that gets done in the private sector. We see some of it in the pharmaceutical area, where there'll be a bunch of misses for every hit, although those are frequently, of course, not known in advance or planned. But if you think about the kind of work that is sponsored by the National Institutes of Health, or you think about the kind of work that AHRQ has sponsored, or that ASPE has sponsored, it's hard to imagine some of that occurring in the private sector. Now, the NIH kind of stuff, I think, is pretty obvious why some of that would be hard to imagine being funded directly in the private sector for as long a period as it may require in the public sector. But if you think about some of the things with the other agencies I've just mentioned, those two are very hard to imagine getting done in the private sector. My introduction to health economics was as the co-director for the National Medical Care Expenditure Survey, which was the first of the many expenditure surveys that are now regarded as part of MEPS, or the Medical Expenditure Panel Survey. The size of that, 26,000 households that went on for a year and a half with follow-back verifications to the physicians and hospitals who were reported to have been seen. It's hard to imagine a survey of that scale occurring in the private sector. Or the Health Interviews Survey, for example, that the National Center for Health Statistics has done every year for years and years and years, is also hard to imagine. Or the Current Population Survey, CPS, that is done every year is hard to imagine. And some of the work that comes out of DARPA, which is the very well-known applied research center that is funded by the military, which has been responsible for many of the innovations that the military has produced with regard to applications in the private sector, is also hard to imagine occurring. But there are other areas that the private sector may not be the only place, but it seems to have happened more often than not. We think about HMOs, or I used to think about HMOs primarily in the role that they were playing and now play to a very large extent in Medicaid, increasingly a force in Medicare now with about a third of the Medicare beneficiaries in HMO, the Medicare Advantage type of plans. But when you think back about when HMOs started, and I'm not even thinking now in the 1940s with Kaiser, but Paul Elwood in the 1970s, you think about how far the private sector preceded the interest in ability, frequently, legislation that was required in order to allow this different organization of healthcare to come to the public sector. And while most of the work on the patient-centered medical homes came out of CMS and their active sponsorship a decade ago, it actually was also something that had started a decade earlier with some activity by Geisinger. artificial intelligence is one of those interesting areas that initially started in the public sector, but the funding was so sporadic and unreliable that it moved to the private sector in order to really be able to take off. And much of what we see happening now in terms of the development of artificial intelligence, which I think we all know we're still relatively early in seeing what it can do, is going on in the private sector. There are some additional places where the private sector has appeared to be particularly strong. So if you want to commercialize a new product or process, obviously the incentives that go on in the private sector make it so much easier to occur there, because all of the drivers that you would like to have present are there as a part of being in the private sector, where you don't have the leisure or luxury of going for too long without being able to show some results, some commercial financial results for what you're doing. You think about some of the wellness plans that were being pushed quite hard by the employer community in the 1980s. They had a real motivation for seeing whether or not they could make their employees healthier. That was obviously to their betterment, even though they struggled making it seem like much of a financial payoff. One of the interesting results that were reported from all of the activity with wellness plans in the 1980s was that the employee frequently felt like, my employer actually cares about me. It didn't have a lot of measurable impact in terms of actually changing the wellness. It seemed to have some positive effects on reducing short-term disability, but it did seem to have more noticeable effects on the attitudes of workers, which of course is not a small issue for most employers. Some of the ways that the private insurers are trying to find to reach out to their employees have been primarily developed by the private sector, by some of the more successful big insurers, not-for-profit and for-profit. Apparently not to the complete liking of all of the employers. That is the at least stated reason that this strange combination of Amazon, Berkshire Hathaway, and J.P. Morgan, the so-called disruptors, have announced that they were coming together not to try to change the world in healthcare, although I'm sure they would like to do that too, but they have been dissatisfied with the ease with which their employees can access information about healthcare, their appointments, their lab results, the kinds of interactions that an Amazon in particular has perfected so well in terms of the retail sector. And we'll see, I'm one of the skeptics about how much difference they're going to make here, but given the successful history that all three of these large companies have had in the past, you can't dismiss them. I think the jury is still out on whether there's been an improvement with Whole Foods since the Amazon acquisition. As a sample of one, I'm finding some inventory control challenges going on. But again, I think that we can't be dismissive of a company that has been as successful as each of the three, but particularly Amazon in this area. Now, why is that? Why do I think that aside from these cases where you want to produce a large change on demand, you want hospitals treating Medicare patients to change how they bill as of a date certain, you clearly needed to have government switching to the use of DRGs. You wanted to change how physicians were paid under Medicare. You did a 3-year transition to the relative value scale in the 1990s. We'll see whether or not the transition to this new system that was part of the MACRA legislation goes on schedule, given the concerns that have been raised about the fee-for-service part, that merit of incentive payment system. But you can only do changes like that for everybody affecting the seniors if government is doing it. But for most of those things that require innovation and a quick ability to be responsive to new changes, that has traditionally been very hard for government to pull off for the obvious reasons of being a part of the political process and having to go through a very deliberate strategy where other people can comment. Some of the reasons that we know government has traditionally done better are quite obvious. When it comes to IT-related issues, and this has been, I think, as far as I know, a challenge not just for the Obama administration, but for every administration, Republican and Democrat, who, for example, has thought it was time to do a major change in the IT part of CMS, has stumbled in some way, in ways that were not anticipated to have happened. The ability to track the same quality of IT-related individual when you have to compete with the private sector salaries, even with some of the exceptions that government allows, is a challenge. And this has been a challenge all along in terms of the IT area for not just HHS, but government in general. It's also hard to have effective multi-year contracts in government. You see a lot of that struggle that has gone on in terms of DoD-related work. You've seen it also with some of the HHS-related work. The private sector doesn't have the kind of appropriations and regulatory process that the government sector has to do, has to respond to. And as people who have been in government sometimes like to quip, private corporations worry about their board of directors and their corporate shareholders. If they're a public company, they can be very demanding. But if they're a private company, then it's whoever is their direct financiers. But it is usually nothing like having the 435 House and 100 senators on your board of director equivalent that the public sector has to deal with. And so the challenges that you have in terms of the public sector being as nimble and quick are just different. Now, we've had a very recent, interesting example of how the private and public sector react and do those things that they do best with the announcement on Friday of some of the changes the administration is proposing to try to be responsive to the general public concern about pricing in Part D in the pharmaceutical area. And it's an interesting example of showing where the public sector can step in to do things that the private sector is unlikely to do. The main focus as I look at the series of initiatives, which I think together makes for an interesting package, is that these are attempts to try to improve both the transparency, which is not something the private sector has any particular reason to try to promote, or the competitiveness in which the industry operates. Again, something that left to its own devices, the private sector doesn't necessarily go look to do. And so if you look at the various activities, it is to try to pull back and make more transparent some of what goes on by the pharmacy benefit managers, to make it more challenging to make use of rebates which I think generally are reflected back into the pricing, but are not done in a clear and direct way, and so make some of the individual nervous about what happens to those monies, and particularly to try to find ways to increase the level of competition that is going on in areas where it might not be robust, left to its own devices. So it's a good example that we've all, to the extent you were following the release on Friday of these series of some 50 initiatives, an interesting way to look at this issue of what in general has been a very effective program, Part D Medicare, which has consistently run below what the forecast and estimates have been with regard to spending, but which still has raised some issues, particularly with the rise of the very expensive specialty drugs that we have seen, and then the government responding by trying to actively introduce pressure for more competition and for more transparency, neither of which are areas that the private sector left to its own device will tend to focus on. With that, let me turn it back to Nancy. Thank you.
Thank you, Gail.